Muthaiya, you are in Chennai now, isn't it? Muthaiya is in Chennai?
Yes, sir. Mumbai, sir. Now, actually, my native is Coimbatore, sir.
Okay.
Now I am in meeting Chennai, Mumbai, sir.
Mumbai, that's great. I feel so. Thanks to network services. No, this is really wonderful. How we were able to meet so close, even though we were far away. This may not be possible in the pre-COVID times, but this has done so many positive things. No, there's no limit to people attending the meeting. Any number can attend anywhere in the world. All these things is possible because of these COVID times.
Yes, sir.
We learned a lot of new tricks to say no. We put technology to the best use.
Really, sir. Yes, sir. Yes, sir. Really, sir. Actually, last 3 days I am in Mumbai, sir.
Oh, okay. Everything is under control now in Mumbai. Things should be.
Yes, sir. Everything in control, sir. Actually, in 2 months before we came here, but they are in the airport itself. They are checking for COVID and everything. But now nothing to checking. But they are asking only.
Okay. In Kerala also it's coming down. Probably.
Yes, Kerala also started to come.
Yeah, coming down.
Okay, Amrishji, are we live? Amrishji, are we live?
Yeah, we are live. We are live.
Okay, so we'll wait another 1 minute.
It's
already 8:30. So I think we can start. Okay, sir, should we start?
Yeah, I'm ready.
Okay, sir. Very good evening to all of you. I welcome all the respected attendees for this particular session. I welcome all the doctors, and on behalf of Curis Mankind Specialities, I today welcome our esteemed speaker, Dr. J.C. Shekhar, who's an MBBS, FCCP, FCGP consultant physician, Subha Clinic from Vada Madurai, Dindigul. Sir, on behalf of Curis Mankind Specialities, I welcome you and I thank you for giving us time for speaking on this topic, dapagliflozin, current perspectives and future outlook. Just to give a brief introduction about Sir, I think people in Madurai definitely would know it. And, we have our regional sales manager, Mr. Muthaiya ji, to, just talk about, Sir, who's such a big name, in this part of the country. So, yes, Muthaiya ji, just would like to put the session to you.
Yes, sir. Sir, good evening to one and all, sir. I personally thank everyone to join with us today to have a rich experience in our brand Justoza, dapagliflozin. I am very much happy to introduce today our program speaker, J.C. Shekhar, sir. Definitely, his rich experience will help us to please. Thank you, sir. Please, sir.
Yeah. I think when I talk about Sir's achievements, Sir did his FCCP 1994, a fellowship course in clinical diabetology from IMA. He's been the award-winning president of IMA Dindigul branch 2009-2010, convener of Club Pulmonale Dindigul since Jan 2014. He's the honorary secretary of Club Pulmonale Jan 2014. He's the honorary finance secretary of Diabetes Club of Dindigul also. Sir is the organizing finance secretary of TRAC. He's currently running a 20-bedded primary care rural nursing home at Vada Madurai. The hospital is equipped with computerized X-ray and fully automatic clinical labs. So, sir, we welcome you and thank you for gracing this.
Thank you, Mr. Bajaj. Thank you, Muthaiya. Yeah.
Thank you, sir.
So I'll start sharing my screen.
Okay, yes, sir.
I think I should be enabled to share the screen. Yeah.
Yes. Yes, now updated, sir. It's visible.
So it's visible. I'm just moving also.
Yes, sir. Yes, sir. Visible and moving, sir.
That's great. So good evening, friends. It's my great pleasure to be here with you this evening and talk to you about a very important molecule that has changed the treatment of diabetes so positively. Such a wonderful drug, which not only diabetologists, but even cardiologists and nephrologists are actually buying for the drug. Such a wonderful drug, dapagliflozin. What are the current perspective of the drug and what's the future outlook? This is a topic which I'll be talking on today. At the outset, I thank my friends from Mankind, Justoza people, for inviting me to give this talk. And I thank every one of you for having logged in. I thank you for your time and your presence. Friends, we know that treatment of diabetes mellitus, its management, has undergone a sea change in the past 2 decades. What was initially aimed at bringing down the blood sugar levels is long gone now. Diabetes is not merely a rise in blood sugar levels. It's much, much more than that. It's a metabolic disease continuum which goes on, which starts by about 30s or 40s and goes on for decades together. It takes along with it hypertension and dyslipidemia. And this metabolic disease continuum goes in parallel to the cardiac disease continuum and renal disease continuum. Especially in Indian patients, diabetic patients who have diabetes at least a decade earlier than our Western counterparts. And as a consequence, competition also at least a decade earlier than our Western counterparts. That's a big thing. This disease continuum has taken a very important place in the management of diabetes. The awareness of this disease continuum. Things have changed now. You aim not only to bring the blood sugars, but with the arrival of 2 exciting molecules, the insulin-based drugs, D4 inhibitors and the GLP-1 analogs, and next ST2 inhibitors. These 2 drugs have entirely changed the options we got.
Sir, sorry to interrupt you. Slides are not changing.
No, I will not start moving the slide. I'm at 2. I'm right my first slide only. I'm giving the introduction.
Okay, sir. Sorry.
Now it's changing.
Yes, sir. Yes, sir.
But once introduced, I'll come to stage like this. I'm giving the talk. Yeah.
Okay.
This is a long introduction. Why this molecule is so important? So when you consider the disease, the metabolic disease continuum, which runs in parallel to the cardiac disease continuum and the renal disease continuum, that gets all the more importance it gets. So when a patient comes to you for the first time with diabetes, when you diagnose him for the first time, you should be aware of the fact that his patients with diabetes don't die of diabetes per se most of the time, but they die due to a cardiac event, an atherosclerotic event, or a kidney failure. That's how it is. Many patients die of cardiac failure or renal failure than diabetes per se. So when the patient visits you at the very first time, your primary aim should be not only to check for diabetes, but also have an ECG done, the microalbuminuria done, to have lipid profile, everything set, and look for the risk factors which can produce to this continuum. And when you see about the drugs which come, as I already told you, D4 inhibitors and the ST2 inhibitors, they are exciting molecules. The role of D4 inhibitors, you are focusing on not only bringing to the blood sugars, you focus on glycemic efficacy also, but also on glycemic durabilities, less hypos, neutral weight gain, and cardio and renal safe drugs. Cardio renal safe drugs with D4 inhibitors. But with the arrival of ST2 inhibitors, you stop talking of not only glycemic efficacy, but also glycemic durability, number 1. Less you reduce weight, there's weight reduction is there with this molecule, this is excellent thing. And number 3, glycemic durability is there, absolutely no hypos. And these drugs are not only cardio safe, but they are cardio protective. They are not only renal safe, but they are renal protective. They protect the heart and the kidneys from further devastation of the metabolic syndrome. This is what this drug is, wonderful drug. It never fails to throw you out of It gives a lot of surprises, positive ones that too. So what are they? We'll be explaining in the next few slides, the next 30-40 minutes. This is the Asian Indian phenotype. We should remember this tells you everything. We are all thin fat Indians, we are thin. Our BMI is low, still we are fat. The so-called Indian phenotype refers to certain unique clinical biochemical abnormalities in Indians, which include more insulin resistance, higher CRP levels, greater abdominal adiposity, higher waist circumference, classical thin fat Indian, which ultimately leads to obesity, lower levels of adiponectin, which ultimately leads to hyperglycemia later on, and characteristic dyslipidemia, called atherogenic dyslipidemia, with high TG, triglycerides, low HDL, and high small dense HDL. Triglycerides are so high in our Indian population. HDLs are so low, and LDL that might be very low, that might be very high, but still it has a lot of high small dense LDL particles. This is the classical Indian phenotype, and increased susceptibility to get diabetes and CAD also. When they coexist together, it's really tough. This is the metabolic disease continuum which I was referring to. The continuum of severity in the metabolic syndrome, it's quite long. The insulin resistance, then the IGT, and ongoing hyperglycemia. Genetic susceptibility plays a very important role in that. Next, the environmental factors, you've got nutrition, obesity, physical inactivity, that hyperinsulinemia, less HDL, more triglycerides, atherosclerosis, and hypertension. And by the time the patient is diagnosed with diabetes, all these things have already occurred. There is the microvascular combination have been there for the past 3 years. Macrovascular combination have been there for the past 5 years. And this, you should remember, hypertension and dyslipidemia, these risk factors are not additive, but they are multiplicative. It's into 2. That's how it is. So atherosclerosis, hypertension, and hypertension, they ongoing hyperglycemia, it's retinopathy, nephropathy, and neuropathy, and disability and death that results ultimately. So SCO different are one drugs, right? When you intervene right on the diabetic onset, we're able to put into check all these ongoing hyperglycemia and the other complications of diabetes. We are able to put a check on the heart failure, to save the heart, on microalbuminuria, and save the kidneys. Right from day one, this molecule is really wonderful. So this is a overview of SGLT inhibitors, based therapy to Asian diabetics especially. And one good thing is, in Asian diabetics, our SGLT inhibitors, they work much better than our Western counterparts. Both DPP-4 inhibitors and SGLT inhibitors, they work much better in our Indian counterparts when compared to the Western counterparts. So what the unmet needs of diabetic patients, diabetic onset at younger age, as I have mentioned, hence could be living with diabetes for a longer time. And that's being countered by sustained long-term data available, at least for 4 years, we got available for dapagliflozin. It causes less hypoglycemia. That can be advantageous in working population. This is one molecule that works different in the insulin, doesn't act on the insulin axis. It works in the non-insulin different axis. That's what it is. And dual diabetes, but with low BMI and high abdominal obesity. Here, SGLT is reduction in visceral fat seen with dapagliflozin, associated with reduction in the abdominal circumference, and this is being sustained over 4 or 5 years. The reduction in weight, whatever weight weight loss you achieve due to your diet and exercise, you can over a period of time you regain this weight. But with this molecule, the weight loss actually sustained and more smooth. And generally, with poorer beta cell functions, classical of Indian people, here insulin independent actions there, so it preserves the beta cells. Beta cells are put to rest, they want less work to do, so they are quite happy, and they apoptosis is much less beta cells when you have at the SGLT with that. And they have higher rate of CV complications. This is countered by SGLT, which reduce glucose, reduce weight, and reduce BP with possible neutral effect on the lipids, thus modify 3 CV risk factors. So such is the beneficial effect of SGLT inhibitors. Dapagliflozin is a novel insulin-independent approach to remove excess glucose. This mechanism we all know. Dapa selectively inhibits the SGLT inhibitor in the renal proximal tubule, as the white particles are the glucose in the glomerulus. When it comes and gets filtered, it's reabsorbed by the SGLT2 receptors in the proximal tubule, and most of the time it's getting fully reabsorbed. And instead of diabetes, this absorption is much more because of insulin resistance, which occurs in the periphery in the kidneys. When you add dapagliflozin, It effectively blocks SGLT2 inhibitors, and thereby glucose is excreted in the urine. Effortlessly, the patient loses up to 70 grams per day, which corresponds to 280 kilocalories per day. A patient who does moderate exercise per day, when he walks for about 30-40 minutes, he will easily lose up to 220 kilocalories per day. And if he takes the dapagliflozin molecule also, 220 plus 280, this leads to 500 kilocalories per day. So he can lose up to 500 kilocalories effortlessly per day. And we know we'll have to lose 9,000 kilocalories to lose 1 kilogram of body fat, our weight. And within a period of 18 days, patient can easily lose up to 1 kilogram. That's how this molecule works to the advantage of the patient, silently and without troubling him. That's the beauty of this molecule. The benefits of dapagliflozin is unique mechanism of action is the main reason for that. DAPA's inhibition of SGLT2 inhibitor results in the daily urine glucose excretion of 70 grams, providing significant HbA1c reductions. This is very, very important. Additional benefits of weight loss and reduction in blood pressure. It strikes the root cause of insulin resistance. DAPA acts independently of insulin mechanism, which means that it works regardless of beta cell function, complements insulin-dependent mechanisms, and the slow propensity of hyperglycemia. Another more important factor is can be given any stage of disease, right from day one can be given, or when two of our oral drugs are not working fine, we want to have the third drug, this can be given. And even the third stage, when you exhaust all your oral drugs and patients still need a good drug to reduce glucose levels, this will come because it doesn't touch the insulin pathway at all. So this works in all stages of diabetes smoothly, and there's low propensity for hypoglycemia also. And there's consistent reduction in HbA1c at week 24 across studies. Ministers have proved beyond doubt that DAPA as monotherapy and DAPA when compared to metformin, compared to sulfonylureas and went on to insulin, it reduces the baseline of HbA1c. The reduction is as much as minus 0.18% when it gives monotherapy. When added metformin, it is minus 0.84, and when sulfonylurea it's minus 0.82, and when insulin is as much as minus 9. This is beautiful reduction just over a period of 24 weeks. The above are not, this we should remember, this is a beautiful molecule. And consistent decrease in HbA1c from baseline at week 24, all dapagliflozin there. Again, this is again the another study which shows as a monotherapy, if the baseline is less than 9, when the baseline HbA1c is less than 9, this reduction as monotherapy as add-on to metformin, add-on to glyburide, add-on to insulin, and add-on to DAPA, add-on to metformin XR, it goes up to, when added to metformin, it's very beautiful. It reduces up to minus 2 grams of HbA1c reduction, 2% of HbA1c reduction you have to see. This is how it works. And even when the HbA1c baseline is more than 9, even in that case, when given as a monotherapy, as an add-on to metformin, different combinations, the reduction in HbA1c is dramatic. As a monotherapy, it reduces up to minus 1.9% HbA1c is being reduced. From the compared to baseline HbA1c is more than 9%. So higher the baseline HbA1c, greater the reduction is. This is the beauty of this molecule. And DAPA plus metformin plus sulfonylurea, the mean change in HbA1c from baseline to 24 weeks is really dramatic. When they combine a metformin plus sulfonylurea plus a placebo, and in another arm, when you combine DAPA, metformin plus sulfonylurea, when the placebo arm, the reduction is just minus 0.717. In the DAPA arm, it's minus 0.86% HbA1c from the baseline. And DAPA works in patients who are not controlled on sulfonylurea and metformin, which makes it the automatic drug choice for a patient who is not able to keep himself in good HbA1c levels with sulfonylurea and metformin. You can add DAPA as the second line drug. And DAPA as an add-on to metformin, patients' HbA1c were sustained over time. This is also very important. You talk about glycemic durability. For a period of 5 years, it is put beyond doubt when combined metformin. It's beautiful. Here, this graph shows placebo plus metformin and DAPA 10 plus metformin over a period of 102 weeks, almost 2 years. The difference in HbA1c is 0.8% difference when compared to placebo. That's reduction with DAPA, which you were able to get sustained over time. And DAPA comparable HbA1c reduction to sulfonylurea at 52-week primary endpoint. And DAPA plus metformin is minus 0.52% at the end of 2 years, after 52 weeks. And with the glycoside metformin, it's minus 0.52. Sulfonylureas, which are acclaimed as one of the most powerful drugs as well as decrease the blood sugar levels are concerned, is equal to DAPA metformin is equal to glyburide plus metformin combination. And reduction has been used with DAPA was sustained over 104 almost 2 years. When you see this graph, the red one is DAPA plus metformin. Its smooth control of vitamin C is down by minus 0.4 and it maintains at that level. Whereas when you have glyphosate plus metformin, glyphosate being a good drug, powerful drug, the reduction has been much sharper with the glyphosate. But after 12 weeks and 18 weeks, it again this reduction goes climbing up, which means there's less control. And at the end of 2 years, it's actually above. It stays above the level of DAPA plus metformin combination. Here, DAPA is controlled smooth and controlled reduction, sustained over 104 weeks. With glyphosate, initial there's a bigger dip, but as days go by, it goes above the level of metformin plus DAPA. And the low incidence of hypos, this is unbeatable evidence, which shows very clearly that with the DAPA and the metformin is just 3.5%, but the glyphosate metformin as high as 40.8%. More than 40% of the patients with glyphosate metformin have a hypoglycemic attack. And mind you, one severe hypoglycemic attack is enough to put the patient off balance. He'll be afraid to take the drug. He'll be afraid if he wants to change the drug. He may even change the doctor also. And it will cause so many severe ill effects. We know about it. The harmful effects of severe acute hypoglycemia episodes. This wonderful drug doesn't produce hypos because it acts on the insulin independent action. And that was assured with significant weight loss also. This is another bonus which patient gets at 24 weeks. As a monotherapy, the baseline weight of 90 kilos was down by almost 3 kilos. When we added the metformin, again, metformin is a slightly reduced weight. From 85 kilos, it was down to minus 3 kilos. Add-on sulfonylurea from 85 is again down. And insulin also. In fact, when you add DAPA to insulin, the weight gain mechanism of insulin and the sulfonylureas, they get nullified when you give DAPA. The patient don't put on weight. You know, the weight gain is so common when you put the patient on sulfonylurea or insulin. That will be nullified effectively when you use DAPA along with sulfonylurea or insulin. And the additional benefit of weight loss sustained over a long time. It's not just 1 or 2 years, 1 or 2 months or 1 or 2 years. Here you could see there are 2 arms, glyphosate plus metformin. The number of patients enrolled were 400 over a period of 4 years. At the end of 2 years, glyphosate plus metformin combination, those patients at an average put on weight of 1.36 kilos plus. Whereas in the DAPA group, it's minus 3.7. I've seen patients who lost up to 5 to 6 kilos of their weight in just about 3-4 months. And some people are even afraid. They say, sir, my weight is getting reduced again and again. I'm really worried, sir, should I change the drug? That's what they say. Some people, they take pleasure because they're losing weight. They attribute everything to their hard work and their diet and exercise. In fact, the thing which is acting is the DAPA molecule. So sustained weight loss is the hallmark of DAPA glycosin. And sustained HBP reduction also, when added insulin, there are 2 interesting things happen. Sustained HBP reduction for 48 weeks in the add-on to insulin trial. This is very clear. When compared to placebo and DAPA, the sustained HBP reduction of almost minus 8.53% reduction is there. And another interesting thing is DAPA mitigates the need for increased insulin requirements over 48 weeks. People who are put on insulin, they may actually need more insulin over a period of time after a few months or so. When you add DAPA to insulin, that increased insulin requirement is much less. This graph shows it with the placebo. The insulin dosage adjusted mean change for baseline is much higher when compared to DAPA, which is almost a flat line when you see DAPA plus insulin. So you don't need to increase the dose of insulin when you combine insulin with the DAPA molecule. And DAPA shows reduction in blood pressure also. It's a beautiful trial which shows in a pre-specified pooled analysis of 12 placebo studies, DAPA reduced systolic and diastolic blood pressure versus placebo. Systolic blood pressure was down by minus 4.4 millimeter, and diastolic was down by minus 2 millimeter. This is being possible by natriuresis and by hypolemia, which DAPA produces. These 2 mechanisms, BP reduction is such a smooth one. And here only I should be careful in old patients who are already on strict control of the hypertension. When you add DAPA to them, should be a bit cautious. You may have to reduce even the drug dosage of such drugs anti-hypertensive agents in them. And when you combine a DAPA and along with amlodipine and the telmisartan combination groups, patients who are resistant to those drugs, even for them, BP takes a dip when you combine DAPA with those two molecules. This also has been proved in this trial. So, but all these inputs, when the reduction in BP, reduction in weight, and reduction in glycemia, reduction in HbA1c, DAPA has been a wonderful molecule, a convenient once-daily tablet. Yes, 110 milligram once-daily oral tablet is enough. In patients with severe hepatic impairment, a starting dose of 5 milligrams is recommended. A well-tolerated dose may be reduced to 10 milligrams. And any time of the day, regardless of meals, can be taken. Not like after, before meals, or along the first bit of food, or nothing like that. Anytime it can be taken. And no drug-to-drug interaction with other commonly prescribed type diabetes medicine. Only thing you have to keep and watch on the kidney failure, CKD. If the EGFR goes less than 50, you have to be careful. If it goes less than 30, you have to stop the drug. But now, actually, a lot of research is going on and how to, when it gives such a good protection to the kidneys, things are going on. We'll get the results soon now. The safety profile of acid inhibitors is well established and includes some mild adverse events. This goes to any drug. Most dental infections are mild and manageable. This is the one common thing which happens, and many times 5 to 8% of the people have dental infections. But this can be again mitigated by three important H. You can remember the H3H. Number one is good hydration. Should take plenty of water. This is the first H. Number two, good hygiene. Patient should be able to keep his genitals clean, hygienic, especially women for during that period's time. You should take the extra effort to keep their vagina and all very clear after every passing urine or passing motion. This is very important. And the third H is inform the health worker immediately if any symptoms like burning or itching or any foul smell discharge in the genitals, which will improve. By these three H, you can mitigate many of the problem of these dental infections in patients who are receiving on DAPA. And they should talk to them about that. Should warn them if they have any problem. Immediately they should get back to you. So, as the increased risk of hypoglycemia when used in combination with sulfonylurea and insulin, this we know about it. And SGLT inhibitor is used in combination with sulfonylurea insulin. A lower dose of sulfonylurea insulin may be considered to reduce the risk of hypoglycemia. In rare cases, serious events may occur in SGLT inhibitors. The diabetic ketoacidosis is rare and can be mitigated again. You should employ the sick day rules. Whenever a patient has acute diarrhea or high fever of febrile illness, when it's going to get dehydrated already, you can't advise him take this molecule because it will worsen further. So in those patients, consider monitoring ketoacidosis and temporarily discontinuing SGLT inhibitors in clinical situations around the predisposed to ketoacidosis, like type 1 diabetes, type 2 diabetes, low C-peptide, and LADA, pancreatic cancer. All these things should be kept in watch. And the increased risk of lower limb amputations, this has been very rarely observed in canonical epilepsy. Appropriate monitoring and counseling should be provided to the patient at higher risk. And all patients should have annual foot testing to assess the liver risk of amputation. And very rarely, foreign gangrene have been reported. So just 1 in million or 2 in million cases have been reported in post-marketing experience with inhibitors. If suspected, the inhibitor should be discontinued and prompt treatment instead. This is the mechanism of action, because there's a lot of glucose in the private parts. One patient passes urine, and patient is able to keep his perineum and all clean. Probably it may predispose to foreign gangrene, which you should be careful. So, the clear contraindications and cautions about SGLT inhibitors. Contraindications are they are not approved for use in patients with type 1 diabetes, which is very clear due to increased risk of diabetic ketoacidosis. Known hypersensitive drug, which is so rare. Lactation, again, there's no data available. And patients who are on dialysis, you should avoid SGLT inhibitors. But whenever you should use, you should be very cautious about the heart failure care. DAPA, when the EGFR less than 30, you should take all the care. For heart failure care, epagliflozin less than 20, you should take care. Pregnancy, you should be very cautious. Increased risk of myocardial infections are already detailed now. If they contribute to volume depletion, consider altering diuretic dose. If applicable patients of heart failure who are on diuretics, you may say adjust the dose of diuretics when you add DAPA to them. Ketoacidosis in patients with diabetes, these are just described. Temporary discontinuation before scheduled surgery is recommended to avoid purchase for ketoacidosis. Assess patients who present with signs and symptoms of metabolic acidosis for ketoacidosis, regardless of blood glucose level. And acute kidney injury and impairment in renal function Consider temporary discontinuing on settings of reduced oral intake of fluid losses. Urosepsis and pyelonephritis, patients who have got these diseases should evaluate patients for signs and symptoms of urinary infection and treat them promptly if indicated. And necrotizing fasciitis of the foreign scan is a rare serious disorder. This we should always keep in mind. The volume intake and eGFR should be monitored when ingesting. This is very important. Their mechanism of action, as I told you, they match the dietary effect of thiazides or do diuretics, and therefore we increase the risk of dehydration and volume depletion and hypertension. Special attention should be given to volume intake when insulin inhibitors are administered with medications associated with volume depletion. Should all the patients take at least 3 ml of water extra per day when they are on diuretics and your insulin inhibitors, then no problem will occur. And an initial fall in eGFR up to about 3 ml may occur upon treatment of GLP inhibitors initially with subsequent stabilization. It can minimize the risk of adverse events with sick day guidance already been described. During periods of illness, contact their doctor, keep close record of blood sugar levels, keep taking their diabetes medications, etc. And stay well hydrated, eat little or often, and maintain a normal meal pattern. Seek medical help immediately. This again, insulin inhibitors are efficacious because they are medications with established safety in therapeutic development, and they effectively reduce blood sugar markers. Generally, they are mild and the side effects are generally mild and well manageable. Severe adverse reactions like decay and foreign scan have been rarely observed. It's 1 in 10,000, and that's what. Use of canagliflozin has been associated with increased risk of lower amputations. So, insulin inhibitors have been shown to improve the CV risk factors. It's very important in diabetes mellitus. All the HbA1c, weight, systolic blood pressure, and diastolic blood pressure. All these 4 important parameters, they are improved with all these 3 beautiful SGLT molecules. And role of DAPA in heart failure. They finished the management of DAPA in management of diabetes with DAPA. Now we go to the 2 extra other fields. As I already told you, it's able to protect the kidneys and the heart. How DPO inhibitors are kidney safe, but DAPA, like it is kidney protective, renal protective and cardiac protective. How is it possible? This is how it is. You know, CV and kidney disease are major contributors to burden of type 2 diabetes. Atherosclerotic cardiac disease and heart failure, one important season. When the combined type diabetes and CKD, it really initiates metabolic disease continuum, which I've been talking right from the day, from the initial, from the start of my talk. It runs parallel to the metabolic disease continuum, the cardiac renal continuum, and it is approximately 1 in 3 patients with type 2 diabetes have CV disease. There is 2 to 5-fold high risk of heart failure in patients with diabetes mellitus. And CV disease is the leading cause of mortality in patients with diabetes mellitus. At least many patients with diabetes, they die due to a major CV event. It can be due to a stroke or even due to massive MI, but it does occur. They die, only very few percent of them, they die due to diabetes per se. So I was already told. Diabetes mellitus alone is associated with the reduced life expectancy of less than 6 years. Patient has diabetes mellitus, we expect his life to be reduced by 6 years. Further years of life are lost with diabetes and cardiorenal comorbidities. This can be mitigated right from the start when you start a DAPA molecule in the day 1 of diabetes mellitus along with metformin. This is going a long way in prolonging his life without any complications. Up to 67% of patients with heart failure are estimated to have CKD. Reduced kidney function is associated with higher risk of CV death, and presence of CKD patients with heart failure increases the risk of mortality more than 25%. They have a bidirectional relationship. Patients with heart failure, they do have CKD. Patients with CKD should always look for heart failure. They coexist. In fact, many a time, patients with diabetes, they die due to heart failure or CKD. They are not much due to massive infarction and all. With so much advances made in the management of myocardial infarction and all, they die due to chronic diseases like heart failure and CKD nowadays. So you should keep an eye for them, and you should always be on the lookout for such diseases in the diabetic patient when you come for regularly for your follow-up. CKD affects up to 40% of the patients with diabetes, and diabetes and the hypertension is the cause of more than 80% of ESKD cases worldwide. This is not only India, throughout the world, it's the same story. Diabetes and hypertension, they contribute to more than 80% of the ESKD cases worldwide. And with diabetes, CV disease or CKD, a 60-year-old man with diabetes and CVD or CKD dies on average 9 to 11 years earlier than a man without diabetes or CVD or CKD. This study shows beautifully that when there's no diabetes, 60 years, end of life, he goes on living happily. But when diabetes mellitus, shortened by 5.7 years, diabetes and early CKD down by minus 9.1 years, and diabetes with major infarction and stroke, your life gets reduced by minus 11.2 years, which is quite almost a decade, more than a decade you lose your life. Especially with heart failure, diabetes mellitus have reduced survival. Long-term follow-up of patients with heart failure in a large nationwide register study. This is a beautiful study. It shows that heart failure with diabetes mellitus, you lose up to 4.6 years. Heart failure with diabetes mellitus, again, you lose up to 3.5 years. Without diabetes, they live longer. Heart failure with diabetes, but the patient with heart failure has diabetes also is mean survival is much less. So prevalence of heart failure is projected to increase worldwide. It's going to increase your patients with acute infarction or angina. They are being prevented from death by some intervention. Intervention cardiology has taken a very good leaps forward, and they are able to save the patient. But later on, those very patients, they'll end up in heart failure sometime in their life. And so prevalence of heart failure is projected to increase day by day. And prevalence of heart failure in the United States over time, from 2009 to 12, it was only 5.7 million. But by 2030, it's projected to go for more than 8 million people. And factors leading to this increased prevalence are: number one, aging population. We live much longer with better care available nowadays. Emerging therapies for improved heart failure outcomes, and increasing prevalence of contributing factors for heart failure. These three important factors that increase the prevalence of heart failure. Hospitalization is common in patients with heart failure. With every hospitalization, multiple hospitalizations are common in the HREF and HPF group. Over a mean follow-up of 5 years, more than 80% of patients with either type of heart failure were hospitalized for more than one time. This on more and more patients, more and more worse the patient gets. Rehospitalization rates are high early after discharge and remain elevated throughout. Minus about 20% of the patients with either type of heart failure were rehospitalized within 30 days. And more than 55% of patients with either type of heart failure were rehospitalized within 1 year. In fact, heart failure is such a cruel disease. It has a 5-year expectancy of much less than many of the cancers which we are really afraid of. Many of the cancers, their 5-year expectancy is so good. 5-year expectancy is so good, but with heart failure, the 5-year life expectancy is much lower with heart failure. The management of heart failure with reduced HFH is multifactorial. Of course, first one will be lifestyle changes in patient education, which includes weight loss, smoking cessation, low sodium diet, etc. And ghrelin-directed heart failure therapies like RAS blockade, beta blockers, aldosterone antagonists, they all come next. And devices also. There have been cardiac regeneration therapy is there, ICD is there, ventricular assistant devices. Transplantation in the advanced stages, gold standard for treatment of refractory end-stage heart failure, and palliative care. In fact, after the arrival of ARNI and the dapagliflozin molecule, the waiting list of patients who are waiting for heart transplant in the United States has gone down dramatically. They are patients who have a HN fraction of less than 25. They've got a heart failure transplantation registered in the United States. Many of them, because their AF has increased to more than 30-35, they automatically they're ruled out of the waiting list for the heart failure. That's the beauty of this molecule when compared with ARNI, especially in treatment of heart failure. This is a DAPA HF design. It's a beautiful worked out design study which enrolled 4,745 patients in about 20 countries. Patients included were New York Heart Association classification 2 to 4 classification. They have included LVF of less than 40, NT-proBNP of more than 600 picograms. They are included patients who had EGFR of less than 30, systolic pressure of less than 95, and type 1 diabetes. They were excluded from the study. They were randomized into two arms. Number one arm, they used to receive placebo over and above the standard treatment for heart failure management. And then on the arm 2, they received dapagliflozin 10 mg once daily over and above the usual routine treatment for heart failure. Endpoints were CVD, heart failure hospitalization, and urgent heart failure visit. So they are followed up for a long period of more than what the result. This study was done mainly because the SGLT inhibitors, no, they prevent the development of heart failure in patients with diabetes mellitus. Can they be used to treat patients in established heart failure? The first question was at the mind of people. The second important question was the parameters of SGLT inhibitor may be glucose independent. Can SGLT inhibitors be used to treat patients without diabetes mellitus in the patient with heart failure without diabetes mellitus? This is another important question. So it was tested. The SGLT inhibitors DAPA was 10 mg once daily, added to standard therapy in patients with heart failure and reduced ejection fraction with both with and without diabetes mellitus. This is how it went. The key baseline characteristics were people who had diabetes were 2,139. Patients without diabetes were 2,605. Patients were into almost the equal number, and male and the mean LVF, all these you can see almost equal. Ischemic etiology, mean EGFR, everything is almost equal in the diabetic group and the non-diabetic group. The baseline treatment given patients who are, some people were trying to take ACE inhibitors, ARNIs, ARBs, beta blockers, MRAs, like almost they are also equal. And what the primary outcome does to see? The primary outcome was severe death and heart failure aspiration or urgent heart failure with patients with diabetes. DAPA proved a wonderful molecule. It was much less when compared with the placebo group with a hazard ratio of 0.75. When patient with no diabetes, also same result. The placebo graph of red line is missing here in this picture, if you can see it. So with no diabetes, hazard ratio of 0.73 is there. And components of primary outcome, again, severe death. Patient with diabetes also, the hazard ratio is just 0.9. It's much lesser with dapagliflozin. And patient without diabetes also almost 0.85. It's much less when compared to the placebo group. And components of primary outcome, worsening of heart failure events. When this was studied, patient in the diabetes group, again, dapagliflozin fared much better than the placebo, the hazard ratio of 0.77. When the no diabetes group, it was 0.62 in favor of dapagliflozin. The secondary outcomes in order of hierarchical testing were severe death and heart failure hospitalization in the diabetes group. DAPA was much better than placebo with a hazard ratio of 0.75. And the no diabetes group, it was again hazard ratio of 0.73. DAPA was having edge over placebo. And total heart failure hospitalization and severe death, including first and repeat hospitalization with diabetes in the patient group of diabetes, the rate ratio was hazard ratio was 0.77. And here, when there's no diabetes, it's 0.73, almost equal in the both people with diabetes and now no diabetes. So, whichever group belongs to, DAPA has the same effect of protect the heart, be it the patient with diabetes or without diabetes. The clinically meaningful changes, the cases you could see, so they showed very clearly that deterioration was there in the diabetes group with the placebo, and improvement was there with DAPA. And in the no diabetes group also, it was same. Deterioration was there with the placebo, and meaningful change in the quality of life was much better when they add DAPA to the patient with heart failure. And what's in renal function endpoint? This also, patient with diabetes, the placebo it was 24, DAPA it was only 18, the hazard ratio of 0.73. And again, the no diabetes group also, the placebo it was 15, the DAPA it was only 10. So this is how it goes. Even renal failure function also, the endpoint, patients either with diabetes or without diabetes, DAPAs have the uniform beneficial effect on the patient with heart failure. And all-cause death, again, placebo was much higher than DAPA, which recorded with the hazard ratio of 0.78. When even the no diabetes group, the all-cause death was much lower with DAPA. The treatment effect according to baseline HbA1c, this also is very interesting. Treatment effect by diabetes with the primary endpoint, if you could see, all patients type 2 diabetes are basically either they have diabetes or not. The HbA1c test shares is less than 5.6 or between 5.7 to 5.9 or more than 6. In all these groups, DAPA is found to be much superior to placebo. The primary endpoint here and all, the DAPA is much better when compared to placebo. Treatment effect according to the baseline HbA1c in all patients, primary endpoint, DAPA is again much in the continuous HI is much better graph than placebo. Also, safety and tolerability of the molecule. Safety and adverse events are patients exposed to at least one dose of study drug. In the diabetes group and the no diabetes group are almost same. Volume depletion, renal adverse events, fractures, amputations, major hypoglycemia, diabetic ketoacidosis, all these were studied. It's as good as or as bad as a placebo, both in the diabetes group and the non-diabetes group, which again proves to go so clearly that DAPA has an independent mechanism in patient with heart failure, which is not related to diabetes or hyperglycemia, in giving the benefit to the heart patients, heart failure patients. So the study concluded that when added to standard therapy, dapagliflozin has reduced the risk of worsening heart failure events and CV death and improved symptoms of patient with HFrEF with both and without diabetic retinopathy. The relative and absolute risk reductions in death and hospitalization were substantial, clinically important, consistent patient with or without diabetes mellitus. The DAPA was well tolerated, and the rate of treatment this condition was low in patients with diabetes. And DAPA offers a new approach to treatment of HRF in patients with and without diabetes mellitus. So FDA has approved beautifully in the May 5th, 2020. DAPA has been approved as fast track approach given to US by has given by FDA for the use of DAPA in the heart failure with reduced ejection fraction. I've been using DAPA molecule in patients without diabetes, patients with HREF so effectively for the past 6 to 9 months, and as an add-on to ARNIs and M2 and diuretics and beta blockers, and with very good effect. Non-diabetic patients with heart failure, I've been using the molecule for quite some time, for 6 to 8 months. Kidney function, the DAPA HF renal composite outcome is more than 50%. What we mean by renal composite outcome is more than 50% sustained decline in eGFR. Number 2, ESRD. Number 3, renal death. All these 3 parameters are much better when compared with placebo, and when you give it DAPA, they are much lower when compared to placebo. So it protects the kidney. In fact, DAPA has been proved to show that patients with microalbuminuria, they get converted to normalbuminuria. Patients with the macroalbuminuria, they get converted to microalbuminuria. And patients who had mild problems, they all get reverted. eGFR actually improves in such patients over a period of time. This occurs irrespective of the stage of kidney failure. Whatever eGFR may be, whatever the kidney failure stage may be, this molecule definitely has a beneficial effect in the improving the function of the kidney. And the DAPA HF change in eGFR per ml. This again, this graph shows it. When compared to placebo, DAPA has a beautiful effect from, and doubling of serum creatinine also. With when you give placebo, it's much higher, 3.2%. Whereas in DAPA, it's just 1.8%. Doubling of serum creatinine is much lower. And DAPA prevents, this is another interesting thing. DAPA prevents new diabetes onset by 32%. Patients who are given dapagliflozin molecule in a patient heart failure, kidney failure, it prevents the onset of new diabetes mellitus by 32%. And this DAPA has a pre-specified subgroups, primary outcome, all these, they all favor DAPA when compared to placebo in the various groups. The effect of DAPA on account to age, whatever age you give, how does DAPA works? This was another parameter which they studied in the study. Outcomes account to age, continuous variable, the primary outcome between the primary outcome, the CV date, hospitalization, urgent visit for a hospital, and all cost death. All these things, you see the green line is much lesser. Hazard ratio is much less when you give DAPA at whatever age group. Age, even as age goes on from 40 years to almost 90 years, shows a very smooth curve, which is so positive in the primary outcome. So renal safety account to age also has been proved beyond doubt. This study shows you from less than 55 years to more than 75 years, renal adverse events, serious renal adverse events, doubling of serum creatinine, all these much less with the DAPA molecule when compared to the placebo. And subgroups also were analyzed. Still, we just go on unless the subgroup patient can give an ARNI or patient may not have an ARNI. Or what's the effect of DAPA? Effect of DAPA in patients with heart failure with reduced fraction treated with sacubitril valsartan, what does it say? RDR, no ARNI, post-hoc subgroup, key outcomes are primary outcome, cardiovascular death, worsening of heart failure, all were reduced with DAPA compared to placebo. And expert outcomes, again, selected pre-specified subgroups, the change in NT-proBNP from baseline to 8 months, again, DAPA is much lesser, lowest levels when compared to placebo, which actually increases it. And the expanded, again, all these parameters, they go on stating so many different small aspects of the big study. The outpatient episodes of worsening heart failure, patients who come as outpatient, how their heart failure worsens, the paradigm HFCR, this one composite endpoint, Expanded component point, prospective collection of DAPA, if episodes of worsening or not recurring IV therapy, this is one point which is studied. And expanded any non-fatal or fatal manifestation of worsening heart failure. This also was studied in these patients. And the expanded, this is how it goes. Placebo, it's 684 patients had severe death or hospitalization of heart failure, urgent heart failure, which is outpatient worsening. But in DAPA, it's much less, it's only 525. Such beautiful molecule, it prevents heart failure in all stages, and severe death is prevented, hospitalization is prevented, urgent heart failure visits prevented, and the outpatient worsening also is being prevented by it. So it's another expanded composite individual components. This also with the hazard ratios much better with dapagliflozin than compared to the placebo. Expanded composite out of all these small points which come when everything DAPA has a higher value than compared to placebo. Severe death, hospitalization, urgent HPS, and a new augmented treatment plan, everything, and the end of day 27, DAPA is, gives a very good picture when compared to placebo. And DAPA, when added to heart failure treatment, produces this effect within a period of 34 weeks. That's another beauty of it. By day 28, we have got a very positive effect with dapagliflozin in the treatment of heart failure. Not wait longer, just 4 weeks is enough to the DAPA have exact positive effect. So, DAPA results are rigorous. Their practice changing. So, main important is the practice changing and paradigm shifting. It's a large trial, multi-center trial, multi-country trial, persuasive p-value, internally consistent in all subgroups, and large effect size. Market reduction was shown beyond doubt. Market improvement, quality of life, on top of excellent background therapy and safe, similar benefit patients with and without tablet. This is what the end result of DAPA result. This is what it shows. And the evolution of heart failure as managed with the arrival of ARNI and of DAPA, it's changed. It's seen change from prevention to treatment, from DM diabetes to everyone. Diabetes, the opportunity, the normal ventricular function is 0 years. If you say preclinical stage of the disease, these 3 big trials, Cavanagh's program, DECLARE TIMI, and EMPARED results are available. The clinical stage of disease from 8 to 20 years on Francois disease, these trials are available. And detectable cardiac involvement was there. The DAPA HF trial, DELIVER HF PEF trial, EMPEROR, PRESERVE, all these trials were there. And all these trials, they prove beyond doubt that these are positive trials which are conducted from 2001 to 2019. All these trials. The one we've been talking about is the DAPA HF trials, which is the latest one. We've been talking only about that only. So it has changed the new pillar of HF ref with diabetes mellitus, ACE inhibitors and ARBs, beta blockers, autosomal MRAs and ARNIs and DAPA. In fact, in the latest, there are only 4 pillars now. ACRB has gone out now. Instead of that, we better go for ARNI. Only the ARNI is not available. The patient not able to tolerate RD, go for ACE inhibitor or ARBs. Whereas in 2021, it's moving forward from neurohormonal modulation and new era. We know good old days where discharges were using diuretics, neurohormonal blockade with started with ACE inhibitors and ARBs, and 2014 humoral modulation with sacubitril, which changed the heart failure perception and the life and mortality and morbidity of heart failure. And with DAPA, it's much more improved. So despite guideline recommendations, heart failure therapy is not currently optimized. Still, it's a long way to go. So this is a therapeutic algorithm class 1 therapy indication for HFrEF. Here we will focus on management patients with heart failure. First thing is ACE or ARNI, beta blockers, MRAs, DAPA, EMPA, and loop diuretic. All these should be started right at the same time. Previously, it was we will wait for some more time. At the second time, after a week or 10 days. So it's not that now. Today, start right from day 1, start on these drugs, and by 30th day, patients will be all right. And other subculture, we want advanced therapy of heart failure, which would be interested. We'll focus on first line, the ACE, ARNIs, beta blockers, MRs, and DAPAs, very much the DAPA or EMPA. And the 22 update for 2017 is the expert again shows HF stage 3 treatment. This is stage 3 treatment. Start with ARNI or ACE inhibitors or ARBs. Here comes add SGLT inhibitor, aldosterone antagonist, diuretics, hydralazine, and ascorbyl if needed, and evaporative. They all go as and when necessary. So drugs recommended in all patients with heart failure, reduced ejection fraction. All patients, 4 important drugs: ACE inhibitors, beta blockers, MRAs, DAPA, and sacubitril valsartan. Of course, it has replaced the ACE1. This is the class 1 recommendation now today, latest guidelines. So it's the 4 pillars of heart failure goes DAPA, ARNI, beta blockers, and MRAs. So drug recommended in all patients with heart failure, DAPAs and EMPA are recommended for patients HREF to reduce the risk of heart failure, patient and death. It's a new recommendation. So pillars of heart, the utility is very much there. As I already told you, the combination of RNA and SGLT inhibitors have reduced the waiting list of patients who are waiting for heart transplant in the US. So SGLT inhibitors and chronic disease is the last part of my talk. The SGLT inhibitors and chronic disease, role of DAPA glycosin, rational by DAPA secretary, despite guidelines recommended therapy, including ACE inhibitors and ARBs, kidney failure, CV combinations remain high in patients CKD. We know about it. The Credence trial showed that cardiac arrest reduces the risk of kidney failure. But SGLT inhibitors appear to be independent of the blood glucose, and the DAPA could be preserve kidney function and improve outcomes. This has been approved by DCJ also, the use of SGLT inhibitors in patients with kidney failure. The primary outcome, secondary outcome also was studied. The DAPA CKD trial, which goes, I running will I brush up this to this slide. The inclusion criteria was there. Primary outcome and study timeline was from 2017 to 2020. After regular review meeting, the independent DMC, the DAPA so much beneficial compared to placebo, recommended that the trial be stopped due to overwhelming efficacy based on 400 primary endpoint events. That's what primary outcomes sustained 50% eGFR decline. The renal events is ESKD. This is being reduced by restoration was up to 13% when you give DAPA when compared to placebo. This is the beauty of the trial. It was so overwhelming. So only the committee has aborted the trial for that. The individual components of primary composite, this is all given here. The subgroup they show they're very good, as I already told you. And statistical significance achieved by the primary and all secondary outcomes is listed here. DAPA is much better than placebos. And this is the one which is really interesting. The ERA, EDTA, European Renal Association, and European Dialysis and Transplant Association, it recommends switching to SGLT inhibitor plus metformin when patients with CKD and type 2 diabetes are HbA1c goal of less than 7 and metformin plus other agents. We know patients with CKD early stage CKD should first drug to comment metformin will be SGLT inhibitors. But here the ERTA and EDTA recommend that when the patient is on when patient is on metformin and some other drug, other different, say AD4 inhibitor or sulfonylurea, and the patient going to develop kidney failure or microalbuminuria, should substitute the other drug with DAPA. This is a very strong recommendation, which goes so much in favor of DAPA glycosin, which really worth recommendation. It goes a long way in proving the efficacy of the DAPA glycosin in the kidney function and all. So an ounce of prevention is worth a pound of cure. So prevention is right from day one. When you start a patient, when the diabetic patient comes to you, you found him obese, he's a smoker, he's a family history of diabetes mellitus, he got a family history of premature death, his lipid profile is high, he's got other dyslipidemia, he's hypertensive, his lifestyle is so awkward, he doesn't go for walking and all. Right from day one, if you add a DAPA molecule for him, it will prevent so many complications, which will be following in the next in the metabolic cardiac disease continuum. So the ounce of prevention is what the pound of cure as far as DAPA molecule is concerned. I finish off with my favorite kural, the Uttranalabum, Pinialabum, Kalamum, Kattan Karvichayal. This shows very clearly that a doctor who treats the patient should see how much the patient is suffering from the disease, how much serious the disease is for him, and how long has been suffering from the disease. And keeping these things in mind, the doctor should treat the patient. This is what the kural explains. I'm such a patient. When you see not only diabetes mellitus, but you also see the CV metabolic disease risk continuum, when you see diabetes mellitus, when you see his weight, obese, everything you take into account. At that place, a DAPA molecule will do much better than other molecules. So this, I end my talk. Thank you so much for patient listening. I'm ready to take up questions.
Thank you so much, sir. I think it was one of the best sessions that we've had. Thanks a lot for such an enlightening talk. Sir, should I straight away ask questions? Should we go to questions first?
Yes,
okay. Sir. So we've received the first question. The question is, when you start basically, a patient on DAPA, what are the changes you made to the therapy? right? I think I can see a couple of questions. One is regarding Ernie, and another is regarding diuretic dose. So, what are the changes that a physician must make when he starts a patient on DAPA? That's the question. Broader question.
And number one, you should keep a close watch on diuretics. If the patient, if you're going to lose diuretics, you may have to slightly reduce the dose of diuretics. You can observe the patient every week, and you may have to reduce the dose of diuretics. Number one. If the patient is an old patient, some strict hypertension control, use some more, one or two or more drugs for hypertension. If BP is around 170, 100 by 70 or so, in that case also, you may have to reduce the dose of hypertensive drug because DAPA does produce hypertension reduction. These two things you have to keep in mind.
Okay. And in case of Ernie, do we need to reduce the dose or can we give it?
No, Arnie not continue the same. Only DAPA also continue the same because both these two drugs are the primary drugs. Diuretics drugs you may have to adjust. Arnie and DAPA they go very well together. No problem.
Right. So I would just like to extrapolate that question. How quickly can we add all four classes? Now the recent guidelines, sir, as you suggested, all four drugs come, in the picture.
Yeah,
how quickly can we get them? Yeah.
Right from day one, you can start one or two drugs, and depending upon that all depends on the patient status. If it's a volume overload is there, if his pulse rate is high, you can start with a beta blocker, or if the volume overload is there, you can start with an MRA and a diuretic. Arnie and DAPA will come as first drugs. Other drugs you can follow as and when necessary, depending on the patient's clinical picture. If it's highly symptomatic, or tachycardia, you can start on diabetic beta blocker right away. Like that, you can.
Right. Okay. So, sir, another question. I think this is a very common question. What, according to you, should do for UTI? Do you see UTI in a lot of patients? And if you see, what should you do? So,
as I already told you, UTI is a very common complaint. It's not very common. I see, if you say 100 patients, 3 to 4% of the patients develop UTI. 3 to 4% of the patients. They come to UTI. Mild UTI is easily manageable. One or two patients have gone. I stopped the drug for them. I have to stop the drug for them. As I already told, there's 3 H is very important. One is good hydration. Number 2 H, second H is good hygiene, which you should treat the patient right from day one. We start the patient on DAPA. Also, take 200 ml of water daily. 200-300 ml of water per day. You can take extra. Number one, it's good hydration. Number 2, good hygiene, especially women folks in their menses time. In Indian people, they don't have pads and all. It's very tough for them. That you will have to really insist on them. Number 3, any dysuria, any itching, any burning, they can immediately contact you. By this preventive aspect, you can this will go wonderfully well. Still, my patients developed. Patients who had long prepuce, now they are developed. Some people have got balanitis. People, women folks, they develop candidiasis of the vulva and all. They can easily be treated. Only when it goes up the ladder, so you can urethritis, cystitis, then you don't stop the drug. There's no doubt about it. External genitalia, you can manage, prolong the drug, the out-get medications. You can give antifungal treatment or antibiotic with indazole and all. With the creams, that should be sufficient. But when it goes up, cystitis or urethritis or pyelonephritis, then we'll stop the drug and then go about.
Right. So, how common do you see UTI with a SGLT2 inhibitor? Do you see it very commonly in your practice?
3%. 2 to 3%.
3%. Okay, so I think that's 2 to 3% only. Right. Sir, one person has asked a very direct question. They say which SGLT2 one should choose, DAPA or EMPA. So I would not ask you directly, but I just want to know, where to place all these 3 or 4 molecules in this class, because the class effect is there, that we agree. I think that you discussed very well. But how do you place all these 3 molecules?
CANA, DAPA, and EMPA they're almost the same. But a lot of trials have been done on all 3 molecules. But there are different sets of population. The EMPA is mainly focused on CV patients who have CV ASD disease they've got. But DAPA is done with 60% of patients with the DAPA people where they had one risk factors, and 40% had established ASD disease. So in such group, different groups, different people, they are all different classes, but class is almost the same. Now, one important point to use DAPA molecule is the price. So 6 months back, it was so high, sky. Even though I had to use great, people who deserved it, they were using it. But I'll tell you 2 or 3 quotes. A patient, a milkman, a daily wage laborer who earns daily some 40, 50 rupees, 60 rupees or so. He has he wakes up at 2-3 a.m. in the morning to go and milking the cows. He has his first cup of tea only at 6 a.m. in the morning. Has breakfast only at 8:30 a.m. For this patient, if you give a sulfonylurea, it's done. He goes to hypoglycemia very frequently. I had a DAPA for that molecule. He lost 3 kilos. There was absolutely no hypos. He was so happy and he wanted to continue on the drug. This is when the presentation was not the previously. Now he is happily on other brands of DAPA which have reduced them. So DAPA molecule is at the economical price is available now. It's our duty to give the benefit to the patients. That's what I.
Right. Sir, even I think like what we are getting response from the market also, that physicians are picking up DAPA very well. Considering the data, as you said in Declare TV trial also, that is much more, that is the kind of patient, usually doctors are seeing in their practice, specifically physicians, and the doctors who see and diagnose diabetes early, right? So, sir, thank you.
Things are very clear right from day one. The patient, as I already told you, patient, high ASCVD risk patient's got, he is obese, he has got a bad cardiovascular history of premature death in his family. His father died of massive MI at the age of 55 years. Mother has died at the age of 60 years. They qualify for DAPA, especially if he happens to be a smoker and is an obese person. Definitely DAPA is the molecule for him right from day one when compared to metformin.
Right.
And the ASCVD guidelines and AD all they told irrespective of the HbA1c level, when patient has established ASCVD atherosclerotic disease, DAPA should be there as the first line. Irrespective of the HbA1c level, it should come as the first line even before metformin. And this, in another slide which I told you, the European Transplant Association, the Kidney Association, they tell patients on combination of metformin and some other drug, if it develops macroalbuminuria, you substitute the other drug with DAPA. That's the beauty of this drug. This is very clear guidelines. It's so beneficial in the retarding kidney pathology as well as cardiac pathology, which are not being thought. A decade back, we never thought this will happen. If a drug which is given the first day will reduce diabetes, reduce weight, protect the kidney and protect the heart. It's just extraordinary.
Right. Sir, I would like to just thank you, I think, for clarifying the doubts of our audience. Thanks a lot. I think most of us never wanted the CME to end. I think it was a wonderful.
No, I thought you had a lot of time. Certainly, I was almost hour, so I had to really rush to the last 3-4.
Yes, sir.
But I think if Mutaiya ji is there, I think I would just like to invite him to thank you and to give the vote of thanks and just on behalf of all the doctors that were listening to us. So we also have our Justoza, the brand for dapagliflozin, API, DMF grade. Our team would be meeting you, in Madurai. So Mutaiya ji,
Yes.
yeah. So I think it was a fantastic session. Over to you.
Yes, sir. Really, sir. Really, sir. Thank you, sir. It's a wonderful session, sir. Your presence and sharing your knowledge to all of us will be very useful and helpful day-to-day practice, sir. And also, I want to thank you each one of the doctors who are spend their wonderful and valuable time during this busy schedule. And also, I request each one of the doctors for our Justoza, dapagliflozin, our Justoza available with ABI DMF grade with internationally accepted quality, and standard, sir. So thank you, sir.
Every company is coming with that. Every Tom, Dick, and Harry comes with DAPA molecule. But
yes,
you stand apart because of this technology.
Yes,
you
sir.
People, because this technology you stand apart.
Thank you so much for your time, sir.
Great.
Thanks a lot. Thank you.
Thanks, sir. Thank you. Bye.